He ended up at
Okay.
UCC. And
so here it is. Now, I kid you not. I swear. I was on call for like I had the major for 2 months after. And then, so the enrollment of the patient was Sunday. So that Saturday, the day before, I told her, no, I'm not came back from
There's still life in the interventional.
take over.
you know, I will tell you.
Oversaturated.
After 2 months, Sunday.
Yeah,
And then here's the bigger thing. That morning, Dr. Nikki invited us, the 4 years, for lunch because for graduation purposes, because she wouldn't attend our graduation because she can't. On his way there, the stroke pager goes off. Patients get it going after 2 months of drops, nothing. When and he got there late, and the second day I hand out the pager. It was, oh my god. So, but I'm glad we got it.
We got people they didn't come from it. They just
No, I'm back. Now I have the major until I leave next week.
They'll sometimes call me up and ask me,
What time is it on this
yes, thank you. No, you from
yeah, actually, Anand is the black guy. Anand is on call.
Geriatrics kind of clearing it out so no one's leaving early. They always schedule people at 8:30 on Friday morning. So I got them.
I mean, it's a good number. I mean, I got this report. I mean, it's not. I mean, I know people are
no longer embarrassed. I've got details. I figured I would run into it.
That's how ours are too. Like they both say they're coming to something that's like
Spain.
I'm looking forward to it.
Yeah. I mean, most of the centers are sitting, yeah. Except Dr. Abraham, is Alabama side. Everyone in the U.S. centers are sitting. Only the Europe centers are but I mean, at least we're on top of it. Residents are aware and we're aware.
have all these different questions.
We get the kind that we're not going
rather than actually studying it. If you have blood complication, they continue to have blood complication. But the model of vessels that over time just shrinks down to nothing. It's very expensive, and so what you want to do is you don't have to it's all of a sudden you're talking about $100,000. Well, so then they had another case, the company they had a decision, and they said, you know, it's because of and so Mohammed went with the patient to see how they did for 2 years. The thing was, they just thought, thank God, it was not. I don't know what they would have done had we had 4 days and close the hospital.
And yours is that too.
But, you know, the 6 steps were expensive, but the outpatient I'm really, I'm a believer in that it's a skill that
And you're on service.
No, they get the first phone call, they see the patients from the beginning, they call them up and put it out, and that I think is the big and I always thought it would be, and it just worked out. I think it's part of our back, and it just worked out.
Well, it's our pleasure to have Dr. Gretchen Tietjen, our visitor for the next couple of days. Dr. Tietjen is professor and chair of the Department of Neurology at the University of Toledo College of Medicine, which I have to stumble over because over 14 years at the same institution as chair, she's been the chair of 3 different institutions.
Right.
When I arrived there, it was the Medical College of Ohio, and then for about a year and a half or something, it was the Medical University of Ohio, and then merged with the university across town, the University of Toledo, and became the College of Medicine for the University of Toledo. Dr. Tietjen has made her name in 2 different areas, related but different, as you'll see today, but really kind of been a tour de force in terms of relating migraine and stroke, and we're really looking forward.
Oh, thank you. Yeah, it's really nice to be here. We're so happy when John joined us back in 99, and very sad when he left in 2010. But it seemed like a really good move, I thought, when he had made the choice to come. But being here, I think he really did make a very good decision. So what I'm going to talk about today is migraine and stroke, and really not much in the way of disclosures. There's one slide or 2 slides that have some biomarker things that I had done with funding from GSK. What I wanted to talk about, the first thing was epidemiology. Since, back when I first went to Henry Ford Hospital after I finished at University of Michigan, I went there to do stroke, and I should say this, but I really hated headache patients. They were just, I thought, oh my God, I can't wait. I'm so glad I'm going into something where that's not an issue. And the first day of my fellowship, 2-year fellowship, I'm in headache clinic, and I thought, what the heck? And I'm normally kind of docile, and I went into that office. I said, I am not seeing headache patients. And he told me that, yes, I was, because there was very interesting relationships between headache and stroke. And I thought, well, nobody's written about them yet. And so this is back in the 80s. And so anyway, but I realized it became very interesting. And if I really were to say where is my heart nowadays when it comes to research things and actually seeing patients, I really do like headache patients a lot. So talk a little bit about the epidemiology, some of the putative mechanisms. I think there's several different mechanisms by which migraine and stroke are related. And then what does it mean when it comes to treatment? So with epidemiology, just for a very little bit of background, this is something that Richard Lipton had put together many, many years ago with regards to the prevalence across the lifetime. And for women, of course, especially at around age 40 where it peaks, much more highly prevalent condition than it is in men. And we all know how migraine is defined, which is a purely clinical diagnosis. But the important thing from the point of view of this talk is that about 20 to 40% of migraines are associated with aura. And that's really where the money is when it comes to the relationship with stroke. So when you talk about the relationship, it could be coincidental in many cases because you're talking about 2 highly prevalent conditions. And so, of course, there's going to be a big chance that anyone that has a stroke may have migraine because migraine is so highly prevalent, particularly in women where the lifetime prevalence is thought to be as high as maybe 30%. And stroke, of course, is a very highly prevalent condition as well. The other thing is, though, too, is that you have to be really careful when doing studies that you don't lump TIAs and strokes together, just because since TIA doesn't necessarily have any kind of a radiological marker, that maybe you're confusing migraine and TIA. And with headache, it's a hallmark of migraine, although you can have migraine auras without headache, but the frequency of headache within a stroke or TIA population, depending on the studies, is really high. Also, though, with focal neurologic symptoms, that, of course, is what we're looking for when somebody gets diagnosed with a TIA or stroke. but it's very, frequent. As I said, 20 to 40% of migraine patients are going to have focal neurological symptoms. Thought that it was easy when it's typical, sort of this positive symptoms, gradual expansion, although I've seen that in so many cases of ischemia, particularly things like cerebral amyloid angiopathy. They tend to a lot of times have these migraine-like progression of symptoms, sensory symptoms, march. But when it's atypical, I think that's when it's hard. When people get older and they start having this phenomenon of aura without headache, when it basilar symptoms, when they have motor symptoms such as in hemiplegic migraine, or the aura is prolonged, is where it gets a little bit difficult to separate the two. And then when we talk about comorbidities, we're usually talking about something that is a relationship that's more than just coincidental, and something that is more than you'd expect just by chance. So, is migraine as a stroke risk factor? So having migraine, does it predispose to having stroke? In some cases, the stroke predisposed to having migraine, or is there some shared etiology that would lead to migraine and also to stroke? And it seems like there certainly might be in some cases that we'll discuss. So years ago, they sort of divided the migraine and stroke into sort of two categories, and I think this was based on a paper that Mike Welch had written with Steve Levine, who were two mentors of mine when I went to Henry Ford Hospital, and one was migrainous infarction, and this is when stroke occurs during a typical migraine attack. So it's not just in a person that has migraine, but it's their sort of typical attack, and then it leaves them with a lasting neurological deficit that could be seen on neuroimaging. So it's thought to be a pretty rare phenomenon, only a 1 to 2 per 100,000, where the migraine, for migraine in general, it's more like 20 per 100,000. And that migraine-associated stroke, which is really what we end up talking about more often, where having migraine is just as diabetes, hypertension, and some of these things may be a risk factor, or at least a risk marker for ischemia. So it's funny because I never thought I really saw a case of migrainous infarction that really and truly met the criteria as they were set up. And then in 1 week, I saw two people that more or less sort of had it. One was a 34-year-old emergency room physician from Detroit that came to see me, and he had had migraine with visual aura for about 20 years, and he really was otherwise very healthy. And he had had a flurry of auras, like one after another, which was very unusual for him over a course of 2 days. And then when it was all done, he noticed that he had a fixed visual field deficit. And he got a workup that didn't reveal anything, and it was sort of like it couldn't be sort of a more picture-perfect case, and there was nothing like a patent foraminal valley or anything else that we saw that was unusual. The other one was a little bit harder. This was the wife of a physician in our hospital, and she was 60, and she had a number of risk factors, but she had had migraine with aura for 40 years, and her children all have the same kind of aura. And she was on a number of different medications for treating her other risk factors. But I had seen her a couple of years ago where she had had a persistent visual aura. We got an MRI scan, and sure enough, she had had a stroke there, and it happened again. And so she got admitted to the hospital, and we knew she had a PFO, and I think she had been on Plavix or something. And the rest of the hypercoag was negative. But when we did a CT angiogram, she really had a lot of narrowing in both posterior cerebral arteries, which she had not had the couple of years before when she had had the same thing. And the thought was, well, are we capturing something? It didn't really fit into this sort of reversible cerebral vasoconstrictive syndrome. There was no thunderclap headache at the beginning, and we had considered that. But was it atherosclerotic disease? She had all these risk factors, or was it actually some kind of vasoconstriction? And decided after a number of months and repeating that it probably was atherosclerotic disease. But again, it was just very scary when she'd get these auras. So about the same time that I was seeing these patients, Neurology and the European Journal of Neurology both came out with series of migrainous infarction. And the thing about them is that posterior circulation in most of the cases, and both of my patients had visual auras, And PFO was more common than would be expected in the general population. So the patent foramen ovale is thought to be, from autopsy studies, probably about 25 to 30% of the population. And that they had good recovery because they were usually pretty small strokes. And from the one paper in neurology, you can see that a number of these, are all in the PCA territory, or at least some of them are, here's in cerebellum. There are some that are not in a posterior circulation, but most of them tend to be in posterior circulation. And in one of the series, it was the average age was 39 years old, and they had low cardiovascular risk profile. So it's not people that you would normally expect to be having strokes, which really sort of is a very interesting phenomenon that I'll talk about as we go through migraine as a stroke risk factor. So the other thing is, when I first became interested in this, there was one study from 1975, and so that was about 15 years earlier. That was in a collaborative group of women having to do on oral contraceptive pills. And actually, Bill Bauer was the first author on that. Yeah, this little, I shouldn't say little guy, but this little town, the neurologist that had run this town forever, had a gentleman that had actually been the lead author on this big paper probably fairly early in his career, and then he'd gone into private practice. And anyway, but then over the years, first I started out, I'd say, one study in 1993, and then there was another study and another study, and before long, there, started to be, 25 studies or so, and there were several meta-analyses grew out of these. But the thing that was remarkable, and I particularly liked the one from Marcus Schurz and Tobias Kurth that came out in BMJ, as far as readability and sort of the way they looked at things. But the interesting thing was, migraine with aura really looked to have more of the risk than all migraine together, but they all had very similar odds ratios, so it's about double the risk if you had migraine with aura. And this is just from Kurth's paper, and you can see where if you had migraine without aura there on the bottom, you had about 23% increased risk, where here, it's about 116% increased risk. So the other things came out of the meta-analyses is that it really looked like it was migraine with aura and not migraine without aura that was a risk for stroke, which is important because 60 to 80% of the population don't have migraine with aura that have migraines. And then it was double in women, but it didn't really look like it was elevated particularly in men. And that it was also in people that were less than 45 years old. And if you look at women who are less than 45, there you have the odds ratio where it's 3.65, so almost 4 times as high of a risk factor as if they did not have migraine with aura compared to a like population. This is a little busy, but the interesting thing was if you look at the proportionality, migraine becomes a more important risk factor, it looked like, from looking at some of these studies in younger population, in that if you didn't have migraine, you'd have about 6 ischemic strokes per 100,000 women. If you had migraine, it was 19. So it's about 3 times as many, or 13 additional strokes, absolute numbers, where if they're older than 45, it was not even double if you had migraine, even though it's more absolute because, of course, we have more strokes as people age. But if you look at, how many strokes per year are we really talking about if they have no other risk factors? And many of these people, unfortunately, do have additional risk factors, so the rates are higher. But if it was just migraine with aura by itself, it's probably about 4,000 additional strokes per year. Now, when you think about stroke rate as, 800,000 a year, it seems like a small number, but these are otherwise young, healthy women that have no other reason to have a stroke. So looking at it as a risk factor, you'd think that it would be more, it'd be tied to the prevalence, the frequency of the migraine with aura. And there were a couple of studies, the World Health Organization study and one that came from a group in Baltimore, where they looked at stroke prevention in young women, and they found that, yes, frequency does play a role in increasing the risk of having a stroke if you have migraine with aura. The Women's Health Study, now this is these are women over the age of 45, and the regular blue is the migraine with aura, the aqua is migraine without aura. And so if we're looking at the relative risk, here's 1, so of course that'd be no relative risk. But it's funny because it's kind of a J-shaped curve for migraine with aura. Like if it's less than monthly, it was 2.5. If it was monthly, it went down quite low. And then if it was weekly, but it may just be, the something about the data, I don't know. But it looked like in people that had weekly migraine, that had migraine with aura as their diagnosis, that they were 4 times more likely to have a stroke. There was a recent paper that was published in Cephalgia last year, though, where Tobias Kurth, and I think it was from this Women's Health study, where he looked at what was the relative contribution of migraine as a stroke risk factor. Was it less important than things like hypertension and obesity and diabetes and smoking? And it looked like it was more important and these are women over 45, so it's not just a young population, but its relative contribution as a risk factor was actually fairly substantial, because we're talking about something that does affect a lot of women, even in these older ages as well. And something that I've never quite understood from sort of the data on mechanism so far, but it looked like it wasn't just associated with an increased risk of ischemic stroke, but also an increased risk of hemorrhage or hemorrhagic stroke. And on a meta-analysis that was done and published in Stroke last year, it looked like there was a slight increased risk overall of about 50% higher risk, so the odds ratio of 1.48. So the question comes up, is it a risk factor like other risk factors? So, you have hypertension, diabetes, hyperlipidemia, and smoking, and then migraine somehow leads to ischemia, and that could either be transient or a definite risk. But I think one of the things that has always sort of been brought up as at least a theory, and then some people have believed that it's really true, and I think I'm falling into that camp more recently, is this kind of a model where maybe sometimes these auras are actually ischemic events. So just to sort of put it in the term that I think of it, is that if you are predisposed to having migraine and you have some ischemia, normally it might be asymptomatic until it was enough to cause a stroke or maybe a more lasting deficit. But maybe in some people it sets off a cortical spreading depression, which we know can be invoked experimentally in animals with some ischemia, can set off this whole electrical phenomenon that maybe that is why some people have migraine, and it'd be migraine with aura, so it'd be sort of a symptomatic migraine with aura in people that had the predisposition. We know it can happen with other conditions, as I mentioned. Amyloid angiopathy is one where they frequently have aura-like attacks when they have ischemia. So one thing that was really interesting, though, is that when you looked at the risk of heart attack, of myocardial infarction, coronary vascular disease, and you used the Framingham risk estimates of the 10-year risk of having an event, those that were in the highest risk, so the most cardiovascular risk factors, had an relative risk of 1. So they were not at any increased risk of having a stroke. These are in people that have migraine. If you looked at the lowest risk, the ones that have no cardiovascular risk factors, less than 1% chance, that's where your risk was highest. And I remember when I was asked to review this paper, I think I had to keep reading it over and over again because I thought that just absolutely makes no sense to me. But there have been other studies since then that have shown the same thing. And there was an interesting study that came out a couple years ago in stroke where they looked at young adults, and they had nearly 1,000, and they had a good proportion of women in this study. And of those that had migraine with aura, it was associated with a low cardiovascular risk profile compared to the rest of the population that they were studying that had stroke. So what might be some of the mechanisms by which stroke could serve as a risk marker or a risk factor for stroke? And I always sort of think of it in terms of arteries, blood, hypercoagulability, and cardiac reasons. But in arteries, we know that some people with migraine, at least during an attack, can have vasospasm. Maybe they're more predisposed. There are thought to be some differences in the elasticity and in the cerebral reactivity. Dissection was another thing, because that's a young person's risk factor where we don't see much cervical artery dissection in an older population with harder arteries. And then the other thing was endotheliopathy. Like, the endothelium is a very active endocrine organ that can cause inflammation and hypercoagulability, and maybe there is changes there that might be related to stroke risk. So this was from Cephalalgia a few years ago, 2011, where they looked at migraine and cervical artery dissection, and they'd been talking about this. I mean, I remember learning this back when I was doing a stroke fellowship, but that it seemed like it was a risk factor. But they showed that there was an overall increased risk of having cervical artery dissection, which is, they say CAD, but it's not coronary, but cervical artery dissection, and it was about double if you had migraine. So migraine not only puts you at risk of stroke related to who knows what, other things, but also in having cervical artery dissection. So it would be important if you see a young person who, comes in and you're taking a history of risk factors that, I think we usually think of cervical artery dissection or cerebral artery dissection anyway, but it's higher in people with strokes, with migraine. So with regards to endothelium function, it's in through all the vessels. There's a lot of vasculature within the brain. And when the endothelium is working well, it helps preserve vascular health from the point of vasodilation. There's some thrombolytic mechanisms, antioxidants, anti-inflammatory, and all these things sort of get tipped in a negative direction when the endothelium stops working well. And all risk factors like hypertension, diabetes, smoking are all sort of increase the risk of endothelial dysfunction. Not going to prolong on this one, but I was reviewing a grant last year for the Migraine Research Foundation, and there's a very prominent group of researchers in San Francisco, not in neurology, but they were looking at endothelial cells, looking at the pain mechanisms and contributing to it. And they put a very interesting paper where they looked at a commonly used prophylactic medication in migraine, which would be beta blockers, and they looked at triptans, and they realized that they have receptors on endothelial cells to act to inhibit endothelin-1, which is a vasoconstrictive induced pain. So, there's a lot of different groups that are sort of looking at things that have just now started to get interested in migraine, and I'm hoping that, with people that are really gifted in research, that we can have more funding, because that's something that the field has really lacked, of the ability to have grants that are NIH funded. So it's hard to move the field forward very quickly. But when you think of endothelial dysfunction, you can think of it in two sort of main ways that it impacts the blood vessel. And one would be activation, or perturbing the blood vessel so that there's more inflammation and thrombosis. And that's something that you can sort of at least indirectly get a feel for by biomarkers, which has been something that I've been interested in. And also the impaired vascular reactivity, which you can look at things like with transcranial Doppler, and then there's another a bunch of techniques to look at this if you're interested in looking at the endothelium peripherally. But it's really interesting that there are a number of conditions that are known to be associated with endothelial dysfunction, not all of them stroke-related, that are also fairly common in migraine in a way that's more than just coincidental. And that would be, one is coronary vasculopathy, that's sort of more of, they called it Rose angina in the paper, but I noticed it was written by somebody's last name Rose. But I always thought of it as kind of a Prince-Meadows angina, but a vasospastic angina. So migraineurs, they're not as likely to get heart attacks from atherosclerosis, but they are more likely to get angina that's related to vasospasm. So you have to almost have a functioning endothelium in order to have some of these symptoms. Retinovasculopathy, and this was from the ERIC study, which is a sort of a Framingham type longitudinal study, and they found that retinal vasculopathy was more common in migraine. And interestingly, it was in a group without diabetes or hypertension. Again, this low cerebrovascular group, even though these were older individuals. Preeclampsia and Raynaud's, which were also associated with it, which are not atherosclerotic diseases. But also, when it came to things like endothelial genes, there's a number of genes that have been associated with endotheliopathies that have also been found to be more common in migraine populations, which is interesting. And there's stuff on either endothelial, sometimes they're referred to as progenitor cells or precursor cells. Now, they kind of show opposite things. Some show decreased number, one showed higher number, but they started looking down into subsets. But what was sort of postulated is that if you have more endothelial damage, there are cells that come out of the bone marrow that increase, that will go and circulate and then go to these areas where the endothelium needs to be repaired. So maybe if you had more endothelial damage, you'd have fewer of these precursor cells because they're all kind of getting eaten up in trying to repair damage. So you could make that argument as to why you saw fewer in migraine. Or you could make the opposite argument that you needed more, and so you had more in the circulation. And so, but in both cases, they were abnormal, but they were abnormal in different directions, so I don't know really how to reconcile that. And I'm not going to belabor these slides. I realize they're kind of confusing, but this was on one where they did notice in controls, if they looked at one population of late EPCs, that they tended to be lower than in the migraine groups. And it's just, I think interesting area of work. But what I was a little bit more excited about is I was asked to review this paper that is coming out, maybe it's already online, but it's coming out very soon. I did this several months ago and read it. But it was about endothelial microparticles, and I remember going into someone's office, oh gosh, probably 10 years ago, and asking him, can I study these in migraine? And he was telling me how kind of expensive it was going to be and complicated, and I sort of gave up. But I really wish I hadn't, because it's very interesting. And I think now is probably a good time to do it, though, because back then I think the studies would have been a lot cruder, because they used to just refer to these microparticles that circulate, and they can be from endothelial cells, they can be from platelet cells, from white blood cells, but it's sort of cellular debris. But now what they've realized is that there's a real signature from them when you can analyze them by the proteins, and they can tell you in the endothelial field, is it from activation, is it from injury, is it from apoptosis, where that's really where it gets interesting. And so what they did is they took a group of young women with migraine with aura, and they analyzed them for these endothelial microparticles, and they found that they were ones from activation and that it was higher in that group. And also what they found is that not only are they a marker for having endothelial dysfunction, but they can actually cause endothelial dysfunction. They know that from animal studies, that if you have a lot of these markers in the system, they will start impairing the endothelial ability to vasodilate and also decrease nitric oxide production. So they sort of work in a couple of different ways. They can both be a result of some stimulus, but they can also cause endothelial dysfunction. And here's a picture of some of these little microparticles adhering to endothelium from electron microscopy. And they knew from this one study, or from a number of studies, that they are increased in a number of diseases that we think of as having endothelial dysfunction, like coronary artery disease, diabetes, and obesity, that they can predict myocardial infarction. One study showed in persons that have diabetes, they cause arterial stiffness. And in this premenopausal female migraine with aura population, they found increased peripheral endothelial microparticles. But we don't know exactly why, but it is thought that maybe in migraine, where there is a lot of increase in the matrix metalloprotease, that there's actually a loosening of these tight junctions that form the blood-brain barrier through proteolytic degradation, and that sort of releases these into the system. So that was really the first study in migraine, and really look forward to seeing more work in that area, because I think it might tell us a lot about what happens to the blood vessels. Now, we had an idea. I mean, I've been wanting to do this for years, and finally in about 2006 or 8 started looking at some of these things. And we chose markers of oxidative stress, of increased coagulation with von Willebrand's factor, and of inflammation with high sensitivity CRP. And this is just a piece of the data, but we found that in migraine, these young women, that it was more common than it was in controls. And so they had more endothelial markers. But if we looked then in logistic regression analysis that was adjusted for all the risk factors in migraine with aura versus controls or those without auras, the odds ratios were definitely higher in the migraine with aura group. So there were things that were different about those that population of persons in a way that you could just see it in regular venous blood. And we had also then later set some of that same venous blood for some other inflammatory markers like IL-6 and TNF-alpha and TGF-beta-1, and found that migraine was also associated with that, and it actually correlated with the headache frequency. And of course, also, since it's inflammation, there's been a lot of interest in the relationship of migraine and obesity, and I'm not sure that just having obesity predisposes to migraine, but if you have migraine and you're on the higher level of weight, that you have more migraine, more tendency towards chronic migraine. And that is probably potentially because adipose tissue increases inflammation. Yeah.
So were those ictals during the...
No, they were interictal. So they were between attacks, and the people were not taking any kind of like non-steroidal anti-inflammatory drugs. Most of them did not have any risk factors. If they had hypertension and they were on some things, I mean, some of the people did have high blood pressure in it, but we did control for it. But for the most part, they were people, they all got drawn at the same time of day, but tried to control for what we did. One criticism, which I think was valid, of like, these are women and they were all premenopausal, but it might have been different times in their menstrual cycle, and we didn't control for that. Although I'll tell you, since they were all not having headaches, usually during the menstrual cycle, I mean during the actual menses, they frequently have headaches, so they were probably all somewhere in different parts of the cycle, but I really couldn't say more on that. So when we did that study, though, I got interested in it, and so I asked a group that was doing a very interesting study called the CAMERA study, which was a population-based study and part of a larger genetics and epidemiology of migraine study in the Netherlands, if we could analyze some of their blood for some markers, because they had taken from this big study a random subset of very well-matched people with migraine with aura, migraine without aura, and controls. And they were people between the ages of about 30 and 60 that were otherwise healthy. And what we found was that these risk things were associated with migraine and with particularly migraine with aura. And it correlated with the frequency and duration of how long they had aura. But there was real differences between the females and the males. So the females are there in kind of the pink and the males in the blue. But if you looked at migraine with aura of high or low frequency, it was mostly in the high frequency where you found that these things were really elevated. And it was in the women and not in the men at all. So that's interesting, because this was all adjusted data. So. Yeah.
What was your cutoff for the frequency?
Oh, when they did the high frequency? I think in this study, since it was a population study, it wasn't real strict. It's not like what we think of as high frequency now, which would be like 10 to 14 headaches a month. It was anybody who had more than one headache a month in that study. So they were taking some people that had migraine, but maybe they had a couple attacks a year. And since it was kind of getting to an older population, there were a number of people that fell into that. But the high frequency ones were those that were more than at least one headache a month. And so ours was from a migraine population where I think they had on average 12 headaches a month. It was really fairly frequent. So the reactivity data, I told you that you sort of could think of migraine as being, the effect on the endothelium could be this activation, which we might see some of these markers, or it might be something in how well the blood vessels react. And there have been a number of studies that had looked at whether there was decreased vascular reactivity, either slowness to vasodilate or to constrict, because this would be a sign that the endothelium or potentially the vascular smooth muscle cells weren't working well. And there was one study that thought that it was mostly that and probably not the endothelium. But since they're so tightly joined and nitric oxide gets generated and sort of moves into the smooth muscle, it's sometimes hard to separate. But it's really been very all over the map type answers. Like there's one where it looked like it was present, decreased vascular reactivity was present in those that they just looked at cerebral circulation. Of course, aortic and pulse reflection work is done in the periphery. So those were all decreased, but there were some that showed increased and others that showed no impairment. And so, you know, what exactly was going on? And then I reviewed this paper, that's actually no longer in press, but this paper that came out that looked very carefully comparing endothelial function in the periphery to that in the central nervous system, and they used transcranial Doppler to measure things, but they gave injections of arginine or something to cause vasodilation. And what they found was you couldn't really correlate it well with the periphery. The periphery could be totally normal and the central activity might be abnormal, so there wasn't really a correlation between those, so they didn't think that it was necessarily systemic condition. But they did find that migraineurs had impaired vasodilatory capacity of the posterior cerebral circulation. So they did find something that seemed abnormal. So the question still comes down to, well, does having migraine with aura or cortical spreading depression, because some of this work is with animals and they don't really have aura, does it lead to endothelial dysfunction? So is it a risk factor in that way? So if you have migraine, you're more likely to develop this, which seems to make sense if you think of the fact that a number of these markers have been looked at ictally. So they get them at baseline, person has a migraine, and they go up, and then they come down after. So the CSD then would lead to a decrease in vascular reactivity, and that's been shown from animal studies where they do the stimulus over and over again, and they get less reactivity. And that some changes may lead to these microparticles that I mentioned. And so the person has a lot of migraines, they get all this cellular debris, and then they develop endothelial dysfunction because of the reaction to the microparticles that adhere then to the endothelium. Another way, though, is does endothelial dysfunction lead to migraine? And, this is really sort of simplifying it, but endothelium 1, which is a potent vasoconstrictor, is known to induce, when it's sort of put right on the brain in animals, induces cortical spreading depression. That reduced nitric oxide increases the susceptibility. So if you have decreased nitric oxide, you would have that in the case of endothelial dysfunction, and it increases the susceptibility to having cortical spreading depression in an animal model. And that endothelial activation, we know, can cause these release of the endothelial microparticles. And then there's these genotypes that make you think that they're genotypes that have been associated with endothelial dysfunction that have also been associated with migraine. And sometimes they're not really associated with migraine in children, but migraine in adults. So it makes you think, okay, they've got this endothelial dysfunction gene. In childhood, it really doesn't make much difference because it hasn't really done much. And then by adulthood, when it is causing more endothelial dysfunction just because of the period of time, that's when the adults start having the migraine. So, I think there may be both these things that are working. But the one thing that doesn't seem to be true is that migraine does not appear to be associated in humans with enhanced atherosclerosis. So it's something to do with the vasculature, and we know that endothelial dysfunction is a precursor to atherosclerosis, but for some reason it didn't seem to really be the case in persons with migraine from large population studies, that they didn't have an increased risk of atherosclerosis. So what about blood things? I mentioned hypercoagulability in what we were looking for in biomarkers, but two reasons, of course, and you think of a young population of women, would be oral contraceptive use and also pregnancy, where estrogen levels are elevated above normal. And one of the things, if you look at, sort of this very careful balance of hemostasis of things that increase coagulation and then things that balance with increased fibrinolysis so that there's not actually any clots forming or any clots that form will then be lysed. Look at what combined, meaning estrogen-containing oral contraceptives are apparently do compared to what would be a bad thing. Well, increased fibrinogen increases your risk, your cerebral vascular risk, and it is increased in persons on oral contraceptive pills. Plasminogen activator inhibitor 1, if that is present, that will increase your cerebral vascular risk. And that, though, actually is decreased in oral contraceptive pill users, so that's probably why more of them don't get clots. Other things, though, like decreasing antithrombin 3, protein S, those are deleterious effects that can at least predispose to venous thromboembolism, and those are both decreased in persons taking the pill. And then C-reactive protein was increased, associated with an increased risk, and is increased in pill users, apparently. So there's a lot of things about the pill that, are a little bit scary. And some people have advocated using pills in treating migraine. And I think that even though sometimes it does seem to be helpful, I think that, you're just putting people at increased risk of blood clots anyway, and I don't think it's probably the best way to deal with it. Now, this is way too busy, but I just want to point out, one thing. If you look at somebody that has, let's say, no migraine, they're not on oral contraceptives, and you give them a relative reference of 1, and then you get somebody who's on migraine and, let's say, low dose, because that's what we use nowadays, oral contraceptives, the relative risk of having a stroke is 6.6 compared to if they had no migraine and no oral contraceptives, and now migraine and oral contraceptives. And if you included the old-fashioned ones, this is from the World Health Organization study, it was 17 times the risk. So all of these sort of show that same thing, that if you have migraine and you combine it with oral contraceptives, even low-dose ones, that you do increase the risk. And whether it's a synergy or more additive, different studies sort of show different things. Cheryl Bushnell had done a study where she looked at a really huge database, one of these that had, I don't know, millions of people in it, that was for people that were during pregnancy, one of these hospital inpatient databases that they had to have had migraine sort of during the hospitalization, and she looked at people that had pregnancy, and what she found was people that had migraine and had became pregnant, that they had a much elevated risk of ischemic stroke. And they also had an elevated risk of hemorrhage, a risk of myocardial infarction, of deep venous thrombosis, and of some cardiac changes, where it was interesting. She couldn't tell if it was migraine with or without aura in the study because they were just coded with migraine diagnoses. But a lot of non-vascular risks were not elevated in a migraine population. So it was just more data to sort of, not very granular, but to show that there was an increased risk. So the other thing in that Italian project I had mentioned, that besides the low cardiovascular disease profile, they did have more, they were also predisposed to stroke if they had migraine with aura, if there was also a procoagulant state, and if they had this patent foramen valley with the right to left shunt. And that's been something that sort of has been very interesting as the putative cardiac risk. And I know there's some debate as to how big a risk factor is this for stroke in general. But in this population, they have found that it is more common in young stroke patients with migraine, and even in young patients without stroke, if they have migraine with aura, they have about a 50% chance of having a PFO from a couple of different studies. So that'd be about double what you would expect. So I thought that was really curious when that came out, like how would that be associated? But if you take the theory of a clot maybe going up to the brain and causing a little bit of ischemia that could either be formed in the PFO or something that came from the venous circulation and just got shunted through there, that might be a reason why people that had a PFO were more likely to have migraine with aura than migraine without aura.
Dr. Tietjen.
Yeah.
Is there any relationship there, or do septal aneurysms play any role in it?
Yeah, that's a really interesting question since it's thought to increase the risk of PFO if you have an atrial septal aneurysm. And I don't think any of the studies really looked at that. I'd have to go back and look at the one by Pizzini again just to be sure that wasn't the case. That's a recent study. I'm sure they looked. But I don't remember if it was just PFO and not necessarily whether that played a big risk or maybe they didn't have enough. And we know that clots, that's a picture of a clot within the PFO, which I always just got off a paper, but I always thought that was really interesting. So they really can get stuck there. They can be big. But we know that 5-HT or serotonin, it can go through the PFO and not get filtered out through the lungs, and that's been associated with a higher risk of migraine. And it causes oxidative stress and activates the endothelium, activates platelets. So maybe it can increase the risk of migraine. And that closure will decrease left atrial 5-HT and MMP9. And that had been shown in a study that was done by Mike Moskowitz's group at Harvard. It came out a couple of years ago. So then one question is, if you had something like PFO with a right to left shunt, that maybe it causes ischemia if it throws up a little clot, and then you get cortical spreading depression, and you get a migraine aura. Or maybe in some cases, the PFO just goes right to migraine. So that's where you have sort of a PFO can lead to migraine, and it can lead to stroke, and not necessarily by the same mechanism. And then just to finish up with a couple of interesting studies, this was from the International Headache Congress last year, but they did it in animals where they took animals that had this familial hemiplegic migraine mutation, and they looked to induce mild ischemia. And what they noticed is that if you induced mild ischemia in the wild type, and this would be the strokes, you had smaller strokes than if they were ones that had the gene for the hemiplegic migraine. They had larger strokes. So the question was, maybe in people, the mild ischemia predisposes to stroke rather than being asymptomatic in certain populations. And then they had another poster from a different group. This was from Jefferson, where they just looked at a population of stroke patients that had to see if migraine with aura predicted increased stroke severity, and they found that it did. They looked at diffusion-perfusion mismatch, and they looked at controls. They looked at all the migraineurs, and they looked at just those that had migraine with aura. And they found that migraine with aura was associated with a larger infarct volume in people that had acute stroke. And it was a study that had 139 people, but it was about 3 times larger, the sizes of the infarct in people that had migraine with aura. Not at the time of the stroke, so kind of interesting. I haven't seen the paper on that yet. So what are the treatment implications? Well, it makes you wonder, should people that have migraine with aura, they're at increased risk, and here you're talking about a young population at particular risk, but should they be screened for PFO? Now you could do it without doing the TEE, you could do it with TCD, but, is there any reason to do that? Because I have people come in all the time asking for that kind of a study, and I'm thinking, what am I going to do with it necessarily when I find the answer? Endothelial activation, should we be looking for inflammatory and hypercoagulability markers? Because these might be the ones that are at higher risk of stroke. I had done a study and published some studies on livedo reticularis. We had found that was associated with an increased risk. And, we know Sneddon syndrome and migraine are associated with each other, and that's a stroke syndrome. So I think the question is, should they be, evaluated with PFO closure? And I think probably not, unless, we know from the closure studies that we shouldn't even probably be doing it necessarily in stroke patients willy-nilly when we find it, because medical therapy might be just as good. That the data from migraine patients did not look to be positive, although closure does sometimes decrease the migraine. And aspirin or antiplatelet agents, especially in the setting of oral contraceptive use, it's unproven, although I would say in many cases I take the risk, and I find that if people have migraine with aura and they have lots of them, oftentimes aspirin. I had one lady this week, and I just decided to try it. I gave her magnesium and aspirin, and every day, and she went from 30, she had 8 auras over a period of 8 weeks, which was really unusual for her. She usually only had one a year. And she had all of a sudden started getting headaches every day, which she didn't know why. And so I just thought, well, let's start out with something simple, not on oral contraceptives. And she came back 6 weeks later and had only had 2 migraines, and none of them with aura. And I thought, there's only one Italian study that hasn't even been published in paper form yet that has really looked at aspirin. And so a lot of people say, well, it's not safe, but, we give people Topamax, for God's sake. I mean, how bad could aspirin be? But this paper made me a little scared, so I'll just point out one thing. This was from the Women's Health Study, where they adjusted, things for vascular disease events, and they looked to see, they gave people aspirin. So people in the study were randomized to aspirin, because I was always asking them, so half these people got aspirin, so does aspirin actually work to decrease the risk of stroke in women that have migraine with aura? And what they found was that stroke risk in migraine with aura, if they had placebo and they didn't have aspirin, was almost 20, and this is 14. In ischemic stroke, it's 15, and that's 12. Hemorrhagic is 5, basically, and 2. TIA, 11, and 10, so there's not much difference there. But if you looked at myocardial infarction, this was scary. In the aspirin group, it was 20, and in the other group, it was 5. And in the coronary revascularization, it's 32 and 19. In death, was double. And I thought, I don't know. I don't want to cause anybody to die from a heart attack. It makes no sense to me. I don't know. I have no idea. That was just like the weirdest data. So.
Well, in that case, is there any internal validation of the study data? And what we are seeing is it reflective that the whole data is somewhat unreliable even?
Yeah, I don't know. I was going to actually ask, I just came across this study, asked Dr. Kurth about this, because I had not even read this paper, and then when I saw it, I was sort of confused. But anyway, so should people with migraine with aura be treated with therapies that improve endothelial function? I'd say yes. Shouldn't everybody be having healthy endothelium? And some of them might be things like just exercise, weight loss, antioxidants, and, ACE inhibitors and ARBs, they're both some studies, there's a level of evidence that they work, at least with lisinopril and candesartan, and I have found that there are groups. And I tried a number of years ago, probably at least 5 or 6 years ago, after those first papers came out, to get funded for a study that would take people that had either genetic markers or that had endothelial function markers in their blood and see if that was really the group that responded well to these drugs versus people that didn't have any increase in their endothelial markers, because, we just treat everybody the same. Maybe we could be a little bit more specific. And it didn't get funded, so I don't really know. But I oftentimes do go to those drugs because especially the ARBs, are very well tolerated. And then the last question was, is oral contraceptive use contraindicated? And there is some disagreement. Oh, yes.
Yeah. What are statins for endothelial dysfunction improvement? Statins.
Statins, yeah.
Is there anything?
I think that I know that there are a few little studies that have looked at statins, and I don't think that they made a difference, but that has been a question because they're so, I was particularly interested because of the Jupiter study where they took people that had elevated C-reactive proteins, and I find really high C-reactive proteins in a lot of the patients when I bother to look. And then I'm going so I always then do a fasting lipid profile, because if it's elevated, then I'll start it. If it's just that, I get a little nervous about starting them, given the data in headache wasn't really that great, but it is a little interesting. I was unhappy to find that Jupiter study was kind of controversial, and a lot of people didn't believe in it, so I wasn't really sure as a non-cardiologist exactly what to make of it. But just to mention on this is that the World Health Organization, American College of Obstetrics and Gynecology both said if you have migraine with aura, any age, don't use it. Based on the data I presented today, I mean, they had the same data. There wasn't anything different that they were looking at. And in the International Headache Society, they said make the case on a case-by-case basis. And the thing is, what if your patient had migraine with aura 20 years ago? They had it with their first attack and they never had another one. Should they never be able to be on oral contraceptive pills where somebody has them all the time? That would certainly be different. So if you have an increase, so what they were saying is if you put people on them and they get an increase in attacks, take them off. Or if they get more headaches and they get worse, take them off. Where the other ones are basically come out like no. And we had a patient that went to Europe for a vacation or a year or something. She went into a pharmacy with a prescription for oral contraceptive pills. And the pharmacist just said, do you have migraine with aura? And she said, yeah. And he wouldn't give her pills. I thought that was pretty weird. She calls up crying. I'm going, I don't know what I could do to talk to some French pharmacist. Just take it to another one. I don't know. But anyway. So factors that increase the risk of stroke in migraine with aura. There's a number of different things that are thought to probably play some kind of a role. So I think that looking for those in our patients and counseling them about them, even when they come in just with headaches. But the question is, what about the ones that come in with stroke? I think that people should start asking about it as a risk factor. We actually put it into the Get With the Guidelines. We were one of the beta groups all those years ago of having migraine with aura sort of added to the database in our little section. But if they have migraine with aura, I think definitely you want to have an increased index of suspicion for things like dissection, for PFO, looking for things like livido reticularis in the skin, checking for hypercoagulability and inflammation, even with sort of non-fancy tests, just things like CRP, unwanted factor fibrinogen, discontinuing oral contraceptives and HRT. I mean, these are people that just had a stroke. And then discontinuing, of course, use of triptans, which are used for migraine, is something that's a general recommendation. So, I think that the point is migraine is with aura is a risk factor during and remote from strokes, and the highest risk is in women, especially those childbearing years with oral contraceptives and pregnancy and high estrogen. That it's associated with a number of different vascular things, but not atherosclerosis. And it is associated with PFO, even if they don't have strokes, for whatever that means, treatment-wise. And that primary prevention of stroke, even though I really am very intrigued by the idea based on my own clinical experience, is unproven. So, and that's it. Thank you.
You said that aspirin could help actually to treat the migraine.
Yes.
Make the migraines frequency. If
yes.
you give daily aspirin, can make it.
Yes.
Lower.
So what they showed in this Italian study, just to say real briefly, is they took a group that had migraine with aura, migraine without aura, and they gave them aspirin. And they found that in the migraine without aura, they didn't see much difference. In the migraine with aura, there was a big decrease. And that's kind of the people that I tend to use it on. Or people that are on oral contraceptives, sometimes I'll do it. Yeah.
I think it's interesting that in migraineurs, is it a migraineur or migraineurs?
I've seen migraineurs once, but most of the time we just say migraineurs, and I thought, well, that other person was probably more, educated. So yeah, anyway, I don't know.
Well, I think it's interesting that pregnant migraineuses who are at greater risk of stroke, but paradoxically, in my experience, a lot of women with migraine, their migraine gets better.
Yeah. So this is a real simple way to think about it, and it's based on some data, is that in high estrogen states, like you would have with pregnancy, where estrogen's about 100 times higher at the end of pregnancy than it would be in a non-pregnant person, that you have less risk of migraine without aura, but more risk of migraine with aura. So it increases, or with the birth control pills, less risk of migraine without aura in many people. Some people get headache, but more risk of migraine with aura developing. And then if you take times where you have like pre-menstrually, where the estrogen goes way down, or postnatal, where it goes way down, then you have an increased risk of migraine with aura and a decreased risk of migraine without aura.
So catamenial migraine is usually migraine with aura.
It's usually, well, no, it is actually usually migraine without aura. So when it's coming down, those are the ones that are migraine without aura. And that's what happens with the catamenial, is that it goes up and then it just plummets. And so those are usually migraine without aura that you're getting more likely, and migraine with aura is not as common in those. Yes.
So during my residency with our headache specialist, I'd seen an unfortunate case of a 60-year-old male presented with new onset headache, which rather quickly became chronic daily headache, refractory to any treatment, and he couldn't find any cause for it. only thing is that the patient had vascular risk factors, and he kept on suspecting that the patient would have has vascular origin of headache. Anyways, was on optimal medical therapy. I think 1 or 2 years later, the patient presented with massive MCA infarct. So the question that I'm getting at is as far as the clinical features are concerned for headaches, is there something which would be suggestive that this would be more than the usual garden variety of migraine, or this particular patient is going to be at a particularly higher risk of having strokes? Or
it's really hard to say. I mean, I'll tell you, when people start getting that daily headache, what I have found in a couple cases, and they didn't have it for years, but I've seen 2 people that I can think of recently that had headache for like 5 months each when they came to see me, and it was one-sided, but it was like daily, and it was really bad initially. Now it wasn't so bad, and I did, and I think I started with an MRV, and then I got confused, like everyone always does, because one side always looks less than the other, and it's always a side with headache, and it's like maybe there's actually a real reason for that. There's some debate, but I ended up doing like angiography, and they clearly had transverse sinus thrombosis, and put them on Coumadin, and the headache just went away. So, I mean, I've started thinking about that more. You know, if I have a person that comes in with daily headache and they hadn't had it before, I mean, I usually, besides prolactin and thyroid, I frequently will look for an MR venogram, because I think there are some that are quite indolent and they just sort of perk along, and just makes me wonder whether we're missing some of those cases, because I don't think you just say, oh, we see this new daily persistent headache, forget about it. There's got to be reason for it. There's got to be a reason. I just think there's a multiple of reasons, and you just got to be careful and look. So, yes?
Is one of those multiple reasons weather changes? You haven't commented on that.
Yeah. I know there are studies that say yes, and there are studies that say no, not important. But I personally think that it is important in some cases, because I will tell you, just anybody who runs a headache clinic or just answers phone calls for it, people all tend to call on the same day. You know, I get maybe a couple calls a day, and then all of a sudden I got 15 calls? Like, what can that be but weather, or, you know, something bad happening in the TV or something? But you know, what else could that be? And so I do think that there are, and I was talking to somebody in Colorado where I guess they see a lot of people that, you know, in the mountains that say it's got to be weather changes, you know, and these winds and stuff, and they put them on spironolactone. And they said that works really well. And I have not tried that myself yet, but I'm going to, and see if I think that these people that swear that it's just weather related, they use like 25 milligrams or once a day or 50 milligrams or something. And I thought, oh, I'd never heard of that. I'm not sure why it would work. And she gave me some explanation that I don't recall. But anyway, but I don't know. But I think I personally do believe in that theory. It's just that I don't know what I can do about the weather. So that when I heard spironolactone, I thought, well, maybe I can do something about something.
Same as Topamax.
Yeah.
They're both carbonic anhydrase.
Yeah.
So what about complicated migraine? Does people not think about that separately anymore? Or?
Well, I think a lot of times complicated migraine is actually sort of more stroke-related migraine. You know, so I think that most people think of it in terms of the ischemic complications of it, and don't tend to use the term as much anymore.
Do you still sort of segregate out positive features or weakness, motor symptoms versus sensory symptoms?
I mean, if somebody has motor symptoms, that makes me very nervous that something else is going on. And in a study that I had done and asking about it, there were about 10 or 12% of people that said they felt that their arm got heavier or weaker, and I don't know that they were necessarily hemiplegic migraine. Real hemiplegic migraine, I don't see a ton of. I mean, I do think it is pretty rare, and oftentimes it's not in family, so I don't know. And they do have markers, I mean, genetic markers that you can get commercially through Athena, but they're so expensive, and where you can get the Catacil ones paid for because they're coming in with strokes. I've never been able to have people not have to pay out of pocket, and nobody wants to do that. So I really don't have much of other than a few patients that I've sent to genetic labs that are researching it, and we've looked at them. I don't normally get patients to actually look at that to see. But that I think is definitely a stroke worry sign, and of the things, and I think I had it on one of the slides, but that where my radar really goes up if they have motor symptoms. Yeah.
That gets you to kind of critique a case I saw yesterday, just very, very briefly. 27-year-old woman, married on some kind of contraceptive cream. Was referred because she's had visual auras, and then in the past couple of months she's developed some sensory auras, so they're concerned, but they're classic auras. Exam was completely normal, but she did have a little murmur that I thought was mitral valve prolapse, so didn't really worry about getting an echo. And kind of talked about, I mean, she's going to graduate school on the East Coast in chemistry, actually, not non-organic chemistry. And I kind of suggested that she may want to switch to a barrier method of contraception, because obviously she doesn't want to get pregnant while she's in graduate school. But should I have gotten more aggressive in terms of saying, no, you have to get off?
It's hard to say. So she was having auras?
Yes.
With these? Yeah, I usually do if they're using estrogen-related products to tell them sort of as a first thing of stop doing that. And it doesn't matter if it's, I'm not too familiar with the creams, but